Thank you very much, Steve, for that introduction. And no, you've just about summarised everything I do in those few words, so thank you. And I'm really pleased to be able to deliver this webinar today. As Steve said, I'd be very happy to, as best I can, take questions as we go along. So please do pop any questions into the chat box. If I can address the question there and then, I will. If it makes sense to leave it a little later in the presentation, I can do that too if I'm going to be answering the point already, or alternatively, we can answer questions later on after I finish the presentation. I'm going to spend the first few minutes just talking about how professional regulation of health and social care professionals is structured in the UK, to give you some idea. I mean, I've recognised a few names on the attendance list, but just to sort of cover off some of the basics about what's here now and what it is we're trying to reform. I'll go on to talk about the reforms that we have actually achieved so far, well, over the last 10 or 11 years that I've been in this world at least, and I'll talk about what we have achieved, what we have been working to achieve, and the ways in which we've been trying to build up evidence and pressure in the system for change and improvement, and then later on talk about where we think things are going in the future. So with thanks to my colleague Leslie, here are some these are not the logos of the organisations involved, I would just say. These are the 9 health and care professional regulators in the UK. These are the organisations which the Professional Standards Authority oversees in ways that I will talk about in a little more detail shortly. I would just point out from the start, we talk of health and care professionals. It's just worth pointing out that these 9 organisations fall underneath our statutory remit as the Professional Standards Authority, but there are some asymmetries, you might say, in that. For example, most of these organisations are UK-wide. However, the Pharmaceutical Society of Northern Ireland is evidently Northern Ireland only, and the General Pharmaceutical Council is the rest of the UK. It's also worth commenting that the Health and Care Professions Council regulates 16 professions, of which 1 is social workers in England only, whereas it regulates the other 15 on a UK-wide basis, and social workers have their own, it's not their own, I shouldn't say that, there is a regulator for social work in each of the 3 other countries of the UK, which are not under the Professional Standards Authority's remit. So maybe that's just a hint to begin with of some of the structural complexity that we think should be addressed. So I'm sure this will be familiar to the content here will be familiar to many of you who are listening. Just to sort of what makes these, I've attempted to set out on this slide, what makes these 9 organisations the same as each other, and that is basically what it boils down to, is that they all fulfil these 4 statutory functions: setting and promoting standards for professionals, maintaining the register of those who meet those standards, and taking action when a registered professional fitness to practice has been called into question, so that complaints effectively. And finally, making sure that the education courses that lead to registration result in the right outcomes. And in the brackets at the end of those points, I've put the terms that are used within the UK system to describe those functions. And of course, I'm aware that in different countries, different terms are often used to describe some of these functions. And that behind that, in some cases, it's a different word used to describe the same thing. In other cases, it's the same words used to describe 2 different things, and all sorts of other semantic complexities that we encounter when we work with regulators in other countries. To continue to expand on the theme of the ways, however, in which these organisations are different to each other, on this slide I've just listed a few statistics from our annual report last year, and I've just put the reference there in case anyone's interested in this. Over page, I think it's over a couple of pages, we have a sort of a set of data, of which these are a few. This is an extract, which demonstrates, well, one effect of which is demonstrate the difference in operational scale of these 9 organisations, despite the commonality of their functions. So there's a huge range of a huge range in the number of registrants on the registers of those 9. There's a range in the number of professions that they regulate. So, for example, the General Medical Council regulates doctors, and the HCPC, as I mentioned before, regulates 16 different professions, including a wide range, including social workers in England and paramedics. There's a huge difference in the number of applications, therefore, that annually they're receiving for registration. There is a fairly substantial difference in the amount of money that they're charging registrants each year for to renew their registration. There are differences for a whole load of reasons about in the time that it takes from receipt of a complaint to final fitness to practice determination. That's where a complaint goes all the way through to a formal hearing, and so on and so on. And there's more data on that in our annual report if you're interested in that. So I just want to make the point really over these 2 slides. Let's go back one. So those are the features that make statutory regulators the same as each other, and put it very simply. And these are just an example of the ways in which the sheer differences of scale involved means that these are very different beasts. Of course, that's also before you go into questions like what is the legislation what's the underlying legislation of these organisations, looking at differences there, what implications that has on procedures and policies and processes, which are, again, the differences are legion. I also want to say a little about the accredited register scheme. This is a scheme that's been in place since 2012, when the authority, it's one of the functions of the Professional Standards Authority, and I'll talk a little more about that more in the round in a moment. But this is part of the framework of insurance, of which also statutory regulation is part. This is a scheme for those professions and occupations that aren't currently regulated by statute, so that aren't a profession that is regulated by one of those 9 a few slides back. It's also explicitly a form of consumer protection, in that we encourage those people seeking the services of those on these registers to look at, as we do for statutory regulation indeed, to check registers before they use them and we try to increase and raise awareness of the scheme. We've accredited 24 registers. The scheme is funded totally separately from our other arrangements. It's funded by the registers, the organisations in question, paying an initial accreditation fee and a renewal fee, and there's a process involving looking at, for example, does the organisation keep an accurate register? Does it require registrants to keep up to date? Does it do all of the things that you would expect such an organisation to do to be able to provide assurance to the public that they're in safe hands? And our accreditation is not about the efficacy of the treatments involved. It's about the effectiveness of the organisation holding the register, insofar as it holds the register. Many of the organisations involved are also representative representative of the professions. That's not true of the statutory regulators, which are concerned with the public interest. So we also, therefore, of course, seek assurance from these bodies before we accredit them that they are able to properly manage the boundary between representative activity and public protection activity. And that's my point about we don't accredit the organisation as a whole, we accredit its register holding function. So just to give you an idea that although the total number of registrants across those 24 is 85,000, which seems quite small compared to the 1.5 million or thereabouts on the statutory regulators, that still does amount to 1 million patient contacts every week or thereabouts. And the range of practice of the registrants is quite vast. And I've given a few examples there. So that is one function of the Professional Standards Authority, the operation of the accredited registry scheme. Most of the functions of the authority, however, do relate to those 9 statutory organisations. So that includes reviewing their performance on a regular basis and reporting on it, reviewing all of the decisions made by final fitness to practice panel hearings, and I realise I have missed off the number, but it is in excess from 1617, if memory serves, it's 4,250 final decisions by all of the final fitness to practice panel hearings from all of those 9 bodies. And we've got powers to take action if we think that the regulator has been too lenient in the sanction, or not in the sanction that it's applied, or if it hasn't applied a sanction. That being the case, because we are established to represent the public interest, and the registrant has scope to appeal if they feel that the judgment has been too harsh. We do policy development and research, we commission research, we encourage other people to undertake research, we hold an academic conference annually, we accept commissions from ministers to provide advice, we respond to consultations on regulatory matters, and that's my area of work, policy development and research. I've just put in italics here, by the way, where the funding comes from for these different functions. And that first bit in italics is intended to apply to all of those first three. With the regulators pay a statutory levy to us to fund these activities. The accredited register scheme, which I've already described, it's not self-funding, and we have been in receipt of a subvention from the Department of Health to make that scheme break even, but it's not. There isn't cross-subsidy between that function and the rest of what the organisation does. And ultimately, we are engaged by regulators in other countries to do a range of different kinds of review, so hence performance and other reviews. Most of the work we've done with regulators in other countries has been performance review-like, in that we've taken the standards of good regulation that we apply in the UK, we've adapted it so it works to assess the performance of a regulation in another country, taking into account legislative differences and so forth. And then we go through a very similar process of gathering in evidence about performance and making judgments about how successful the organisations are. We, as I'm sure many of you are aware, within the last few years, we've reported on, for example, the College of Registered Nurses in British Columbia, the Royal College of Dental Surgeons in Ontario, for example. Mostly, in fact, not entirely, but mostly we've worked in English-speaking countries, it is true. And those also, for various reasons, are the same countries which have similar, in many respects, regulatory arrangements to our own. Government commissions, including special reviews, involves, for example, a special review or investigation of one of those 9 regulators, which falls outside of the cycle of performance reviews for some reason. It can also include, I think I actually covered this under policy development and research, it can also include for example, some advice to ministers on, the first one that comes to mind is advising the minister on the regulators' processes for assessing the qualifications of applicants for registration from outside the UK. Those often would result from a specific issue or a specific problem. Before I go on to talk about regulatory reform, what we think we've achieved so far, I wonder if I think we'd scheduled originally to maybe have a pause or a hiatus, but in any case, I wonder whether anyone's got any questions at this stage. Do feel free to enter them in chat if you have. Maybe we could give it a few moments to see if anybody has any questions. Doesn't look like anything's coming through. So
sorry, Douglas, we have one question that just came through. So it was, were those international performance reviews commissioned by the regulatory body itself or a government agency that oversees the regulator?
That's a very good question. Well, to date, with one very recent exception, they have been a combination of, no, actually there's two exceptions that I can think of immediately. Mostly the reviews have been performance reviews that have been commissioned by that organisation who have invited us of their own volition they've invited us in and they've paid us to do a performance review. There are some exceptions to that. One is now a couple of years ago when we won a tender to apply the methodology that we developed in the UK for assessing cost effectiveness and efficiency of regulators. We then won a tender exercise, so it wasn't being commissioned by the Australian Health Practitioners Regulation Agency. It's being commissioned by government to contribute to the review of APRA. I think that must be 4 years ago now. So that was slightly different. And then I'm sure some of you are aware that our Chief Executive, Harry Caton's recently been appointed by the Minister in BC to lead a review into the regulatory of dental surgeons. That was announced, I think, early last week. So mostly we've been directly invited by that specific regulator rather than by government or oversight body, but there are some exceptions. I can tell you
sorry, there was one other one where you mentioned that the PSA reviews decisions by FTP panels.
Yeah.
What about discipline panels, and who is responsible for discipline matters? Does the PSA review these decisions as well?
Yes. I mean, fitness to practice panels, that for us encompasses any matters that are raised with the regulator that call into question that individual fitness to practice. And that can range from poor clinical care, different forms of professional misconduct. So yes, and they would be. Now, as I understand it, generally within Canadian regulators, the final stage, there are different committees for different kinds of case, whereas in the UK regulators, the final fitness to practice hearing, as we would generally call it here, would look at all different kinds of case. So it would be heard in this. So within each regulator, they have, as all regulators all around the world, have their own process for receiving the complaint, preliminary investigation, a more detailed investigation, and if necessary, formal proceedings, such including formal hearing. So that's with the regulator. And then all of those decisions that get through to the final stages of the final hearing, we then review that decision, and the regulator will provide us with an account of how the decision was reached, how they decided to apply a particular sanction, why they decided not to apply other sanctions. So in the first place, it's all with the regulator, but then we review those cases that have gone to the final stage. I can see there's a question from Ivor Bourgeot. If Douglas can provide a bit of details of the type of support they provided in Canada, that would be helpful. If by type of support you mean the type of support that we've provided to regulators, so that so what we have done with regulators in Canada, let me think. We did a performance review of the Royal College of Dental Surgeons of Ontario, and that was, yes, to regulators, thank you. Yeah, we did a performance review of the Royal College of Dental Surgeons of Ontario, and that was, we went through, I think, the full range of standards that we apply to a regulator in the UK across all of those 4 functions I listed earlier on. And we adapted the standards so they fit the legislation with the agreement of RCDSO, and we then invite the regulator. We invited them to provide us with evidence of how they felt they were meeting those standards. Where we didn't think we had enough evidence to make a judgment, we asked for more evidence or different kinds of evidence. We then spent, I think it was 3 or 4 days, the Chief Exec and I, the Chief Executive Authority and I, with the regulator in Toronto, so meeting key members of staff, meeting stakeholders, talking about, so we understood both better, so we had a better understanding both of the performance of the organisation and the context it was working in, and the other organisations with whom it worked, such as the Office of the Fairness Commissioner. The review in the review of CRNBC more recently was, we included, I'm sorry, I can't actually remember from the top of my head whether within RCDSO we included governance, but we certainly did with CRNBC. So it was both standards applying to all of those, we assessed them against, that is, standards applying to all of the 4 core functions. But then in addition to that, and I'm afraid I can't remember at the moment whether we did RCDSO with RCDSO as well, we set a series of standards that applied to governance. So, for example, does the board have effective oversight of the executive? Is there does strategic financial planning happen in such a way that the board assures itself that the regulator has the resources it needs? Does strategic planning by the board take into account the views of patients and the public? So we had a set, I think it was about 7 or 8 standards that we used, and assessed them against specifically in relation to governance. We are currently working on, we're in the very early stages of working with the engineers and geoscientists of British Columbia solely on governance-focused review, and it's likely that we'll be using a very similar set of standards there. And we'll be similarly looking to see evidence of how those standards are met. So, for example, we might look to, my colleague who will be going to Vancouver at the end of next month will be attending board meetings. He'll be looking at evidence and that the executive is being held to account, that it's being constructively challenged and so forth. That's the kind of process we've been through. We also, I wasn't directly involved in this, provided advice possibly 3 or 4 years ago to the government in Ontario. I think we had provided advice on an accredited register scheme, although I'm a little vague on that, I'm afraid. Does that answer the question? Great, thank you very much. Shall I continue to talk about reform now? Steve?
Yeah, I would just keep going through your presentation and the top 10, and then Kaelan can share his insights as well.
Great, thank you. Well, I'm keeping my top 10 till the end, because I think my top 10 arise from what I'm about to say. So I've got my top tips right at the end. So I hope that the title of the presentation didn't imply that we've got further than we had in terms of achieving regulatory reform. I think we have got a long way. I think what we've got a long way with is actually building the case and the evidence that reform is needed. However, that's not to say that we haven't had some possibly what you might think of as more tangible results along the way. So, again, during the last decade or so that I've been working in the authority, there have been we have some very significant achievements. The reform of the governance of the regulators being, I would also just actually say before I meant to talk about some of these items that sadly I was able to draw on the announcement of the resignation of our chief executive this week, and he listed out what he saw as the some of the achievements of the authority during his tenure, and so I have this is validated from our chief executive. These are the things that he's most proud of. Anyway, so reforming the governance of the regulators was a major progress. The boards became, or the councils rather, became much smaller. This is the governing councils, the governing boards of the organisation, much smaller, and they now have equal membership of members of the profession and public representatives. That was and also within that, the authority itself previously had a board which comprised, half of them were the 9 presidents or chairs of the regulators that we oversee. So we had a florid conflict of interest in our own governance arrangements. We also now, the authority has oversight of the appointments of people on those regulators' councils. We don't actually approve appointments. It's not that. We approve that the process has been. We look for evidence that the process has been completed properly and fairly. There's the introduction of the accredited register scheme, which I've already talked about. Possibly more than any of those, it's the way that we have built the evidence base and the need for reform. We've built pressure in the system towards achieving more radical rearrangement, restructuring of the way that regulation is done in the UK. So I'll go on to say a bit about that. I've just got a few slides where I'm saying what it is that we really want to see change and how we're now in a position where actually these changes are truly in sight. We want to see clarity for the public about what regulation is, what it's for, and why it's there. And also, how can the public engage with it when they need to? We want it to be easy for employers to check registration and to check the status of somebody, applying to them for a job, for example. We want regulation to both not be and not be perceived to be a barrier to innovation and workforce flexibility. We want professions to be treated fairly, in particular in fitness to practice processes. We want to make fitness to practice better, that whole way in which practitioners who aren't meeting the standards of the regulator, how regulators react to that. And we want, and I'll talk a little bit more about that in a moment. And we want to see the shift of the focus of we want to see a shift in the focus of the regulators such that they are using their position within the whole architecture of the way that the health system is organized to support attempts to prevent practitioners, professional health and care professionals from getting into trouble in the first place. The fitness to practice function, is the most expensive proportionately of all of those 4 regulatory functions that I listed earlier. And when you look at the cost of a fitness to practice case going through, about 4 or 5 years ago, I did a very rough calculation where I looked at, literally divided the total amount that the regulators were reporting in their annual reports by the number of fitness to practice cases that they were saying that they dealt with in that year. And just to get a rough idea of the average cost of a fitness to practice case. Now, of course, that ranges from something that they're told about that they say, actually, that's not for us at all, it doesn't meet our thresholds, it's for the employer to deal with, right up to cases that last for years, highly complex, heavily contested, and therefore extremely expensive. The average then, by my calculation, was about £16,000. By now, if I did the same thing now, maybe it would be £20,000 or thereabouts. But it's extremely expensive, and that's only the cost in terms of money, because then, of course, you've got the cost in all sorts of other ways as well. So you've got the cost in terms of harm to patients, of course. You've also got harm and distress to the patient's relatives and family. You've got damage to the career of the professional. You've potentially got professionals having to leave the workforce who could have gone on for decades to there's just cost after cost after cost, and it mounts up. There's almost, when you start to try and unpick the costs involved, where things go wrong, it goes on forever. And it's, when you look, though, at the originating incidents that resulted in something going wrong, often it's not rocket science to be able to see ways in which those situations could have been prevented. So the whole focus of being upstream is about regulators looking at in particular, the data that they hold about the situations where things have gone wrong, and using that and extracting learning from it to prevent things going wrong in the future, and communicating that learning to the people who will be able to do something about it. So we think that a reformed regulatory system should be proportionate, it should be simple to understand and simple for those operating it, and it should be efficient and cost-effective. I hope those are non-controversial statements. And that it should have a clear and shared purpose of protecting patients and reducing harm to patients, promoting professional standards, and securing public trust. What we've argued for, and maybe some of you have looked at some of our policy publications, is a single regulator, a single regulatory organization, which not only encompasses the 9 existing organizations, but then also has the capacity to expand to incorporate the accredited registers and potentially other parts of the health and care workforce as and when necessary. We think there's scope for, in particular, a shared tribunal, so that's the final fitness to practice hearings, but then also other functions as well. And this is something I could potentially talk about for hours, and I'll spare you that this evening, but there is lots of detail in some of our publications that I'll list in a moment about how we think this could be done. We think that those professions where there's a high risk arising from their practice should be issued with a license, and we talk about we think there should the as it were level of regulation that's applied to any particular group should be arrived at as a very considered and analytical process, which looks at the risks involved in a particular area of practice, and then the other mitigations that are already in place to manage those risks. I'll talk a little bit more about that in a moment. Pardon me. So, over the last, there's been the effort and energy that's gone into preparing to reform, whether in the way that I've just described it or according to other notions of how the future should look, has been now building up since at least April 2014. And there have been a series of both series of things that happened outside the authority have been published by other organisations or have happened, and in between which we've carried on putting out our thoughts about how the future should change. So in December 2015, the government undertook to issue a consultation on reform. We published Regulation and Thought, then Philip Dunn made a further statement reinforcing that undertaking to consult in October last year. We published our magnum opus, Right to Touch Reform, in November, and then the UK-wide consultation by the 4 health departments did indeed happen between October last year and January this year. And at the current time, we are looking forward to hearing what the outcome of that consultation process is. Our own submission to it, which draws heavily actually on Right Touch Reform that we published in November last year, is available on our website. At the moment, my colleagues in the policy and research team have been amassing all of the responses of other organisations, and they're analysing the range of responses that have been received. If anyone was interested to see who has responded and what their thoughts and what their positions are, if that should be of interest to you, I'm sure that we would be able to provide a list of the organisations who we know who responded to that consultation, and possibly a link to that as well, although we won't be publishing our own summary of what the responses are. That's not our place. And I think I've already talked about some of these desirable features of what we think it should look like in future. And I think I'm not going to labour these points at all. And I hope that the most of those are things that, which are not really too controversial. Moving on. This is just I've put this slide up just to demonstrate to you how radical some of the questions were that were being asked, such as this is in the UK consultation finished a couple of months ago. So the consultators were asking how many regulators there should be, if there were to be less than there are now, how they might be configured, or as I said, what we would really like to see is just one. Questions about data sharing, which speak to the point about preventativeness, the relationship of regulators to supporting professionalism, and how, if reorganisation were to result in efficiencies, how savings might be introduced. It was radical, possibly more so than we had hoped, but we welcomed it very much. So as I said, I've kept my top 10 till the end, and I hope that most of these 10 actually now emerge naturally from the things that I've already talked about. I think the first two, patience and resilience. Oh, by the way, sorry, just to explain the title of this slide. When I was preparing this, and I saw that the frame for it was to do a top 10. I thought, well, I'm not going to sort of work laboriously through everything we've ever done and work out. I'm just going to sort of just put down the first 10 things, because I think probably, having been in this game so long, the first 10 things that come into my mind are probably what I would arrive at if I spent days thinking about it. So the first two, I'm sure, will be self-evident from the sheer amount of time and effort that we've put into getting where we are in terms of patience and resilience. Conversation speaks to the importance of constantly maintaining a dialogue with all of our stakeholders, which we've sought to do throughout, and that's regulators, that's government departments, government officials, academics, the public, communicating as much as we can in all sorts of different ways. Number 4, building on achievements. Achievements create momentum. You know, if you can achieve one thing, it proves that you can achieve other things. And I think that's true of anything that you set out to do in life, really. Maximizing opportunities. Sometimes the opening is there to say what you want to say and to express your ideas, and sometimes it isn't. And sometimes you can't say what you want to in a way that's going to be received well. So, but when opportunities do arise for whatever reason, when ministers, for example, are open-minded to suggestions because of particular things that might have happened, then those are times to really go for it, to make your case. On expanding the evidence base, we've put a great deal of effort into, and this actually speaks to the next point as well, we've put a lot of evidence into trying to expand the range of academic disciplines we hear from in formulating our ideas. And moving on to the next, and sorry, that's academic and other kinds of research. And in the next point, I'll just give you an example of that. We funded some research by Professor Rosalind Searle at Glasgow University, which was published last year, where we asked her to bring a psychologist's view on the data that we held about all of those thousands of fitness to practice cases, and to apply her insights to what might be done preventatively and what the sort of different circumstances, what the commonalities and so forth. And we don't think that had been done before. Consensus is hard to achieve, and the more you go into detail about, for example, what does harm prevention look like, what's the regulator's appropriate level of responsibility. It's, you know, the first statement, you know, a statement such as regulators should be more concerned with harm prevention is one thing, but then actually really working out what that means for everybody in a way that everybody can agree with is very difficult. And of course, finally, evidence-led reform is obviously where we would all want to go, but sometimes it's trumped by political expedience. We've developed in our publication, Right Touch Assurance, a method for, and I think I mentioned this, analyzing risk, and then proposing an appropriate form of regulation for a particular group. Sometimes, despite our efforts to create evidence-led process, politicians will make decisions on another basis for a whole set of other reasons, and that is a fact of life. So those are my top 10, and there's my email address and our website. And that was all I had to say.
Great. Thanks very much, Douglas. We'll maybe just move over to Kaylin quickly for some reactions to your top 10 list and other comments, and then we'll open it up to questions and answers. So while Kaylin's talking, if anybody has any questions for Douglas or for Kaylin, please use the chat box below, and we'll address those shortly.
Thanks, Steve, and thanks, Douglas, for joining us today. That was a really interesting presentation, and I you know, this is the second time we've interacted professionally. I think the first time I was just picking your brain over the phone, build up to some work that we were doing back in the middle of 2017. Sure. So my approach is really going to be just to give folks some background about what we've done with respect to the topic of reforming the oversight of the workforce in Ontario. I'll quickly go through some of the findings, but the questions I have from you at the end of that are not necessarily in relation to your top 10 list, Douglas, but most kind of reading between the bullet points, so to speak, on some of the things that popped into my head as I heard you speak. They relate to some of the things that were coming out of our own work. So just to give everyone on the call or the webinar some sense of background, in 2017, so last year, about the same time last year, we were engaged by the Ministry of Health and Long-Term Care in Ontario to do some follow-up to our initial work on workforce in 2016, which really focused on approaches to planning for the optimal workforce, given all the changes that we see in Ontario over time, as well as what we can expect in the future as, you know, we have an aging population and more care moving out of hospital and formal settings into community and home care. So we were engaged, and we we were asked to do a follow-up to that, which focused less on the planning side, but on our approach to oversight in Ontario. And this is where we engaged Douglas and his colleague, Harry Caton from the PSA to provide us with some perspectives on this. So we also met Harry in person in Toronto in August of last year in the build-up to what would become 3 citizen panels, which engaged 37 citizens to weigh in on the issue of workforce oversight in Ontario, as well as a dialogue which we convened in September of last year, which engaged 25 policymakers and stakeholders from across the province and internationally to weigh in on the same issue. So some of the key findings coming out of that work that we had from citizens was that the big challenges we face in Ontario, and I think this is really interesting. I'd like to get your opinion on what you've done in the UK to get the insights from citizens as well, Douglas, but we'll get to that in a second. But what we found in Ontario was that they felt that the current approach to oversight has really not adapted to vast changes in the healthcare system from when it was initially kind of implemented in 1991. I mean, we're still utilizing the framework that was developed in the early part of the 90s. They felt that there were too many oversight bodies, and this directly relates to some of the things that you grappled with in the early days of the PSA, Douglas, and now that kind of has resulted in you moving from to 9 and perhaps even fewer bodies overseeing the regulators. Not enough emphasis on soft skills is another big thing that came out of the citizens panels. And not enough emphasis in approaches to oversight on the personalization of care. So a lot more focused on the what are people doing and how they are doing it from a clinical standpoint, and a very technical bent to that clinical standpoint. Citizens also felt that oversight bodies weren't really set up to prioritize their interests. So you spoke a little bit, Douglas, about the balancing act that needs to be played between advocating for the interests of the public, which I think in many cases is the primary focus of what you do, but in other ways you have to balance that out with the interests, of course, of the regulators and the professions themselves. Citizens felt there wasn't enough accessible information that they could access with respect to the regulators themselves, and not enough ways to engage in the regulatory process. So that was the big takeaway from citizens in our work. With respect to policymakers, they felt that in general, the biggest challenge was that, very similar to what the citizens said, the current approach to regulation in Ontario is not fit for purpose. It may have been in the early 90s, but is no longer fit for purpose. And I think that there are many similarities in this kind of idea in what you were dealing with back when the PSA was first established. But again, now it sounds like you're dealing with this again, Douglas, where there's a lot of changes happening and you're going back to the drawing board and trying to find the most optimal approaches to adjusting to the ways in which the UK NHS is adapting over time. Some of the big things coming out of the stakeholder dialogue as well is that we need to push forward with a more risk-based approach to how we're approaching our oversight function. So I know that the PSA has done lots of work with respect to assessing risk, and that's part of your right touch approach, I believe, and you can correct me if I'm wrong, Douglas. You focus heavily on competencies, which we don't tend to do so as much in a consistent way across professionals in Ontario. But again, that was coming out of the stakeholder dialogue as another way forward. And finally, performance management and measurement of oversight bodies themselves. So you engage in that routinely in the UK. Yeah. We don't necessarily do the same thing from on high in the same way that the PSA does. So we don't routinely assess the performance of the regulatory bodies in the same way that the UK does. So the stakeholder dialogue resoundingly came out with these 3 ways forward. Additional emphasis, I think, was played up in 5 different domains by participants, and there's a lot of overlap in what I'm hearing you say is happening in the UK as well, Douglas. So one, we need to focus more, not just on the professions themselves, but on the employers of professions, and that might differ a bit from the UK context, because of course we have privately owned and operated hospitals, whereas the UK NHS, I know there's a slightly different relationship between the private sector and who owns hospitals. It's slightly different in the UK than it is in Ontario, but for us, resoundingly, a lot of emphasis needs to be placed on how we're engaging those who employ, not just at hospital level, but also in community care organizations, workers who are providing essential services to the population in Ontario. Needs to be much more emphasis on patient engagement, so really aligned with your approach in the UK to reform the board. So to have that, I believe it's a 50-50 split with the citizen and patient representatives and professional representatives and other people on the board. So that came out from Ontario as well. the need to be proactive, not reactive, and we can get to that in a second when I ask my follow-up questions. The need to balance consistency in approach across professions with flexibility across different types of workers. So I think this is bang on what you're discussing right now in the UK about moving to a single assurance standard with that body. And again, I don't know if it's possible in Ontario, but it did come out as something that we need to focus on here as well. And finally, to ensure any new approach that we adapt is flexible enough to be changed if needed in the future. So that was one thing that I don't know that there's a right answer to this. It's just that systems change, and we often talk about stasis in systems, but at the end of the day, they do change over time. If you look back to the way that the systems in both the UK and Ontario were set up 25 years ago, you would say lots has happened in terms of change. And, you know, it just seems like in the moment on the margins, it's not a lot happening, but at the end of the day, we'll inevitably be going back to the drawing board 25 years from now saying our approach then was wrong too. So I think that this is something that's always going to be there. The big questions for you, Douglas, I have one related to something that came out of the citizen panel. So one was about the soft skills emphasis. So I know that you talk about fitness for practice a lot, fitness to practice a lot, the FTP. I'm just wondering, since it's such a big emphasis on what was coming out of the citizen panels in Ontario, what is it, in your opinion, that needs to be done to ensure there's a balance between the technical things that you know, professionals are required to do to provide optimal care, as well as the soft skills, the bedside manner? So they're quite different things, but increasingly I'm seeing there's kind of convergence. That's the first question. Second question I had for you, and I believe Harry talked about this a lot in private when we were at the ministry in our meeting, was just the role that you feel the media plays in pushing forward opportunities for reform. So you're probably at this stage in the UK in a different situation than you were when Harold Shipman was making the news. So I'm just curious as to what your thoughts are on that in the current climate in the UK. You may or may not know that in Ontario we just came through with a pretty devastating case of a nurse in some long-term care homes who was convicted of 8 counts of murder. So, you know, we are kind of back in the Shipman days if we're making parallels to the UK. But I'm just curious as to know your sense about the role of the media and, you know, its importance in pushing reforms forward. And finally, this is a much more technical question, and it's kind of personal interest, kind of, you know, if you're in Ontario, we have 26 oversight bodies overseeing 29 different health professionals. You have 9 overseeing 16, and they're considering even fewer. How did you come to terms with grouping in what I think is the catch-all category of health and social care workers? So what is it about the professionals that you have in that group that, you know, you thought would be a good fit for that grouping? So, you know, it's a more technical question, but so interesting to me.
I might just go backwards through your questions.
Sure.
And I'll probably have forgotten the first one by the time I get there. I'll probably have forgotten the second one by the time I finish the first. But going to the third question, the reasons for which particular professions are regulated by statute and are therefore one of those 9 is, well, they're there for all sorts of reasons. The General Medical Council has been in existence since 1858. And that model that the General Medical Council established back then has developed and evolved in a piecemeal way. Other professions have become regulated for all sorts of different reasons, possibly in relation to crisis, responses to crisis, possibly because they were very effective at self-organizing and lobbying politicians to become statutorily regulated. And maybe even some of them have become statutorily regulated because of the levels of risk they present to their patients. So we haven't had, as an organisation, any hand in determining who is and who isn't statutorily regulated in the past. We haven't. So, for example, in the time that the authority has been in existence, those 9 have continued to exist. Now, one of them, the Health and Care Professions Council, has taken on the regulation of social workers in England, and that was as a successor arrangement to the social workers in England being regulated by the now non-existent General Social Care Council. Now, possibly ironically, given what we've been arguing for, there is now a new regulator just for social workers in England being established. and our Department for Education is leading on its establishment. We've been advising on that. It's not necessarily what we would have wanted to see, but there's, it looks like that is going to happen. One thing that struck us when we were particularly when we were doing that job in Ontario, when we were doing the performance review of the Royal College of Dental Surgeons in Ontario, was just how many organisations there are where there's an individual organisation or a small group, or where there is a function which in the UK would be more familiar with being absorbed within a bigger range of functions by a bigger organisation. And that seemed to us, I'm not going to say it with names now, but it seemed to us in a general sense that presented all sorts of risks. Firstly, because to work together as a unit, with a whole load of a multiplicity of different boundaries, because you've got a large number of small organisations. Also, because small organisations are more vulnerable and less resilient to crises themselves, and we've seen that in the UK. When I think about 7 or 8 years ago now, our General Chiropractic Council, which is I think the second smallest, went through great difficulties when it received a very large number of complaints about chiropractors. And because of its size, possibly didn't have the ballast to be able to deal with that sort of a crisis situation, and became overwhelmed. I'll come back to the question that's just been posted in the chat box in a moment. So yeah, so we haven't determined who those 9 are, and but we would like to see one. We may, in terms of groupings, maybe at the end of this process, if the government proceeds to legislation to actually enact some of these reforms, we might end up somewhere between 1 and 9. Who knows? And then if we were to go there, then there are different ways that we would be looking at to in which different groupings could emerge. So it could, for example, be based on people working together in teams, or, for example, working in similar kinds of environments. So what we might refer to as the high street regulators, the people who work in the high street, who work from small, possibly in smaller premises, in small commercial organisations, dealing directly with the public. So there are various ways that it could be carved up, but we're some way off. So making the arguments for and against different configurations if we don't end up with just one at the end of the day. So that was, I think, the third question. Sorry, Kit. What was the second question?
Yep, the second was the role of the media and how important it is to have those kind of headline news stories to drive.
Absolutely. Well, I would say that the media is interested when there's a crisis, and it's fairly seldom that the media is interested in regulation preventive. So they're not interested in a regulatory crisis as such, most of the time. But when crises occur, and whether it's a kind of crisis in which the media is likely to be most interested, and where there's a sense of public outrage about something that's happened, those can be the moments that, I suppose, those are the opportunities that might need to be maximised. Obviously, nobody wants to have to rely on crises to develop, for reform and development and improvement, but the fact is that sometimes crises do present those sorts of opportunities. In the UK at the moment, some of you I'm sure will be familiar with a case of a Dr. Bawa Garba, who has been found guilty of gross medical manslaughter, and the GMC subsequently struck her off the medical register. When you look at the circumstances, it's a terrible case in the sense that a young child died of sepsis in hospital. The child was under the care of the doctor in question, who missed signs of sepsis. However, when you look at the case more broadly, the situation was an awful one. She was responsible for multiple patients. It was a very stressful situation, and she was relatively recently returned from maternity leave. So the case, I'm not seeking to present an authority view on that particular case or to give a sort of an authoritative account of it, just to give you a flavour of what that case is, what's involved in that. But it has resulted in a review of this particular legal definition of what constitutes gross medical manslaughter. So gross negligence medical manslaughter, which is then asking wider questions which may result in building the impetus towards regulatory reform. And I think that's just a fact of how public policy proceeds. Of course, what it doesn't replace is the long-haul efforts that are required to put organisations like ours in a position where, when those opportunities arise, we've got everything ready, we've got our arguments lined up, we've got our evidence lined up, and we've got our proposals ready to go. And that clearly comes through long-haul efforts in the long term. So, Kaylin, what was the first question again? Sorry.
The first one could be probably addressed. I know we're running out of time, so sorry, Steve, but the first one could probably be addressed quickly, just about how the issue of citizens and patients really placing importance on soft skills, bedside manner, all of those things, despite the fact that regulators historically have tended to focus on the technical aspects of care.
Yeah. I'm not sure. To the extent that this is something that this is a regulatory matter in the UK at least. I mean, all of the regulators set out a set of standards that apply to their registrants, and that obviously that's true in many regulatory systems. It's the bedrock of it. And certainly within the UK, those standards encompass the full range of skills that they need to be able to demonstrate. All of the regulators now have requirements, different as they may be, about the ways in which registrants are required to demonstrate to the regulator, possibly via their employer, that they're continuing to keep up to date through continuing professional development activities, through revalidation for doctors. They have to continue to demonstrate that they are meeting the standards across the whole range of skills that are required. And additional to that, of course, the regulators are assuring the courses that people are graduating from. And I think within that area of the regulators' activities, there has been increasing focus on health professionals and social care professionals with the full complement of skills that are required. So, to the extent that it's a regulatory matter, I'm not quite sure where to go with that, to be honest. I think that's sort of maybe a wider social question about what sort of health and care professionals we want.
Great, thanks, Douglas. We're pretty much at time now, so if you want to maybe just quickly address some of the questions about the impetus for regulatory reform, but then we'll wrap up to be cognizant of your time and everybody else's.
Well, I suppose a couple of ways to answer that question. Firstly, it's, that, as we were just saying, impetus comes from crisis. Is there evidence that improvement is needed? I'll see if I can go back. If I can go back through my presentation, some of the things I might as well have rushed through. Maybe I didn't really expand it. I mean, that's what I've put there, the what are we trying to achieve slide. Those are the areas where I suppose we have elsewhere in some of our policy publications set out the ways in which our evidence for the ways in which our evidence firstly for the ways in which those are things that we want the regulatory arrangements to be able to be, and also are the ways in which we think it's falling short of that. And we've expanded in some of those publications on, for example, on the complexity of the current arrangements and the problems that result from that, and what sort of performance measures to determine whether improvements are being achieved. Well, that kind of depends where we go next, and it kind of depends the extent to which to the extent which the government agrees with our vision of what the future should look like. But whatever line that government takes in the future, we will be ready to implement a performance review regime that accordingly. And I just think I'll sort of just look at this last question, and then we'll probably have to call it a night for me, lunchtime for you. Another question: to what extent do you feel the media or public is able to distinguish a true regulatory system crisis and a bad clinical outcome or a bad regulatory outcome? Don't know. I think that would depend. Insofar as the media is concerned, that probably depends to a large extent on who it is reporting it exactly, which branch of the media it's coming through. Certainly, we see examples of the regulatory system, for example, taking the blame for crisis, where in fact often it's really the failings are those of the organisation involved or the individual involved. We see individuals taking the blame for crisis when actually it's the system that they're working in which is more likely to be at fault. And bad clinical outcomes are going to happen sometimes, and we know so much more about human factors, the way that people behave and their judgment is affected in certain situations. And those can be very complex and very subtle discussions that maybe, for the most part, the media isn't necessarily the right place for those difficult arguments to be expressed.
Well, thanks very much, Douglas. I really just
My
want
pleasure.
to say thank you very much for taking the time to join us today, and thank you to Kaylin as well.